So I want to introduce this guy, Dr. Bruce Dahlman. We've known each other for a number of years now, and we first met and you were working full-time in Africa with Africa Inland Mission.
That's right.
And tell us a little bit about what you've been doing over the last couple decades of your life, and then we'll bring Keir into this conversation at some point in time too.
Yeah, thanks, Greg. So my name is Bruce Dahlman. I'm a family physician by professional training, and as the Kenyans like to say, I love the Lord Jesus, and He's been my Savior. That's how they introduce themselves anytime you go to Kenya. I love it. It's where things start. I worked in a small northern Minnesota rural community 100 miles from a referral hospital for the first 8 years of my career, and God called our family to Kenya, East Africa, with AIM, and was assigned to AIC Kajabi Hospital. When I arrived, we were 4 family physicians taking first call, 2 general surgeons doing all the surgery, so 6 physicians for a 200-bed hospital. Over the last 25 years, Kajabi has grown to become a regional referral hospital and teaching center now with about 20 to 30 consultants, 20 to 30 residents. It's exploded. And that's been by God's grace and by the incredible teamwork from our Kenyan colleagues, and the transformation that's occurred is, of course, by God's provision. But that transformation in the middle of it was when I was there in the early 90s and 2000s, was taking on education as a paradigm for what this hospital could become. It was very clear that the long-term missionaries that 6-physician team was all expatriate, all missionaries, and the long-termers were not coming, and the short-termers were coming and going, and it was a lot of work to get short-termers in and out of a hospital and make it work. And what I realized as a medical director is that though my Kenyan staff were not telling us, they were exhausted. They were exhausted, taking care of all of us coming and going, coming and going, coming and going. And so it became clear that the way forward was to be an educational institution to replicate what we were doing in good quality postgraduate education. So my position in family medicine is where I started, and a giant of our profession is Dr. Dan Fountain, passed some years ago, who came to Kenya in 1995 and said, guys, you know, we're not winning here, all right? There's lots of needs, and we're not going to making it with white guys coming over. What are we going to do? We're going to set up education. And within a few months, Dr. Fountain had been able to start half a dozen family medicine residencies in Congo. There was a lot less bureaucracy and regulation for him to work through, so they sprung up within a year. And those continue to this day. I was just in communication with the head of that group of residencies from Kinshasa just this last week. In Kenya, it took us 10 years to get from idea to regulatory approval for a family medicine residency. We took the long path because of the need to help people understand family medicine. It wasn't a recognized specialty, and that became an important part of our work in the go-slow approach to make sure that what we were doing was indeed something that the health system needed and how we could fit in to make a healthcare system function better. So from that, we've moved on to try to help set up other residency programs across Africa, and have formed an organization called CAP, Christian Academy of African Physicians, which is a parallel to the good work that PACS has been doing for the surgical education. And together we hope to be becoming more, well, I don't know if we can move, can't join at the hip, I guess, yet, but I could move a little closer to you, Keir, and see that we can hopefully collaborate more towards building a strong church hospital system across Africa.
So tell me your thoughts on, you know, we talked a little bit this morning about what does it look like to do missions with people versus to people? And I think that's been kind of what you're saying in a different way, is how do we build on national capacity? How do we build up national capacity in a way that supports and sustains, you know, Christ-centered healthcare? Tell me your vision for for CAP, and then I may ask you the same thing, Keir, is what does this look like over the next 10 or 20 years for medical education? And then is there a way that short-term folks who are interested and have a passion for medical education is there a way that they can fit into what you're doing?
I have one of my mentors as I came to Kenya as a family doc that came to Kajabi about my second year there. His name is Dr. Ray Downing. Unfortunately, just passed away here a couple of months ago. He writes a blog, and one of his books that he finished just a year before he died, title is Global Health Means Listening. And I'm going to encourage you to put that in your presentations in the future. Global Health Means Listening. And the whole point he's bringing is, yes, we come with all of these complexes about how we're going to help, but really, what does it mean? And what we learned in listening as we were recognizing our inability to make an impact by just being a few doctors in a big hospital, all these scores of hospitals across the country in Kenya and, of course, East Africa and beyond. How do we make the real impact? Well, only by seeing the skills and the interest and the compassion of the physicians, nurses, and other cadres of workers, building into those facilities. And I believe in the church health system because we do have a motivation for what we do that is built on the King of compassion. And when we emulate it's not about me, it's about Jesus, you reach the different levels in how you impact at the individual care level, in your interactions with your colleagues, and you're looking at a kingdom work that's occurring. So listening first, what did the primary healthcare system of East Africa and Kenya in particular, what were they needing? And when we started our investigation about is family medicine something that's needed in this culture, we looked to studies that had been done a few years before our question, and the answer was coming from outgrowth of the work that WHO had been doing, that yes, primary care is where the work needs to happen. And what we realized in the East Africa context, at least, is there was no person that was really coordinating the primary healthcare work. There was a big emphasis on, community level work, nurses in clinics, nurses in the community, but then the connection to the next levels as people had more difficult circumstances and needed hospital care, no connections going on, no communication going on. It was in all the books from the very beginning. Morris King in 1970s and beyond. It's all in the books about how it all supposed to happen, but it wasn't happening. So we came together actually as a group of family physicians in Africa in Rustenburg from across the continent, Rustenburg, South Africa in 2010, and more or less understood that the primary care health system needed a consultant. And so the family physician's definition there is a consultant to the primary health care team. Once that was codified as Africa's definition of what they wanted for what our role could be, then we could design educational curriculum to meet that. And of course, it takes many steps and many people, but through that, the discipline of family medicine has now established itself in a half a dozen countries, starting with Nigeria, where American family physicians in Jos Evangel Hospital saw this same need and consulted the same way in 1980s and began family medicine there. And then in the 1990s, Dan Fountain in DRC in Congo, and then on into East Africa as well. And it's now growing so that there can be somebody who's helping to coordinate and be responsible for and listening to the needs of a health center clinical officer and the clinical questions they have to give best care and coordinate the collaboration coming up and down the referral systems. All of that's coming together in much more detail now. And we're seeing from the fruits of our education, and the first class of the Kabarak University Family Medicine Residency just graduated in last September. Half a dozen bright, enthusiastic, incredibly gifted people who are now going to be taking their places as the PAC surgeons have been doing for 15 years. or more in the church hospitals.
That's exciting. So, Keir, tell us a little bit about PACS and what you guys are doing, and maybe what your vision is for surgery across sub-Saharan Africa.
Yeah, so those of you who are familiar, back in 2015, Lancet Commission put out their assessment of global surgery. The neediest places on earth were in sub-Saharan Africa. Least number of surgeons per capita in the whole world. And that was recognized in the mission world years prior, but now validated in 2015. And so back in the late 90s is when PACS started to really with the model, and it shouldn't be surprising, right? I mean, Scripture pretty much has all the answers for us, and we just tend to complicate things and don't want to just have it be simple. But 2 Timothy 2:2, these things you've heard from me in the presence of many witnesses, teach to able men and women who are also able to teach others. That's it. That's a training program. It's not more complicated than that. There's another way to look at that I've learned over the years. An African proverb, I don't know where it comes from in Africa, but I've heard it from a number of different countries. If you want to go fast, you go alone. If you want to go far, you go together. So if you put those two concepts together, that really fits the model of PACS. Initially started with mostly expatriates, or almost all expatriate trainers. Very Western program, 5-year residency, 5-year discipleship program. When I took this job, I wasn't interested. If they weren't interested in emphasizing the discipleship, they needed to find somebody else, because training a bunch of surgeons that don't love Jesus is not what I'm interested in doing. So that's what we do. It's training and discipleship. It's a 5-year program. We're currently, as I shared before, in 10 different hospitals, 8 countries. The vision is not to take over Africa. That's not what we're doing. We have introduced and partnered in a different model than what Africa is used to. So Africa had a very university professorial pathway of training surgeons. And so at the end of your surgical residency, you did a thesis. Anybody here defend their thesis to finish medical school or PA school or nursing school? No, we don't do that. Well, maybe one. Okay, one person, thank you. But we have a very clinical focus on our training, and it requires lots of contact time between the consultant and the resident. And that's the model of what we do that is a bit in contrast to what the typical African, and I'll say Africa, although I know that's generalizing and it's not always true. There are pockets that are an exception. That's the way life is. But generally speaking, it was a different kind of model. And it is that you're considered a student as a resident. You're a student, and the equivalent of that would be our residents, but not treated in the same way that we treat residents. You know, if we didn't have community-based training in surgery here in the US, 60% of our surgeons would not exist. 40% of them are trained through an academic, university-specific institution. We would be in the same place as Africa is. So it seems obvious to me that the solution is to introduce another style or another way to train surgeons. COSEXA, College of Surgeons of Eastern, Central, and Southern Africa, started about the same time as PACS with a similar vision, a decentralized, out of the university kind of training in surgery. We've become very close partners with them. They're not a Christian organization, but they appreciate our input into the process of the COSEXA examinations and other things, and we appreciate their validation of what we're trying to do as well in introducing a different model of training. So vision for the future is not to grow PACS, it's to glorify God. That may happen through growing PACS, and it may not. PACS may only be around another 10 or 20 years, and it may disappear. That's okay, because we're not here to glorify PACS anyway. We're here to glorify God. And so that's really the idea of our graduates going to places to support mission hospitals, to work as surgeons in hospitals that otherwise don't have surgeons, to the more rural places. And just like here in the US, you tend to stay where you train. You tend to go to a place that was similar to where you trained. That's the same is true in Africa. You tend to go because you're comfortable there. You tend to go to a place, or you stay in the place that you were trained or that is very similar. So now if you're trained in a rural mission hospital, your comfort level of going to another rural mission hospital is significantly higher, and your likelihood of going and staying is also much greater. Of course, if that hospital provides free care and says we don't pay anybody, you can't really go there and not eat. So you have to have a balance. So there's a lot of different things coming together.
How many surgeons has PACS trained thus far to date since you guys have started?
Yeah, so we've issued 98 certificates to 92 different graduates.
Two of them are here at this conference. You can look for Agneta Odera and Jacques Ebele. They're two of our, I'll say, shining stars that God has used mightily already in their short careers, and expect that he'll use them in the future. Excellent surgeons, both of them. Jacques is in Malawi. Agneta is in Kenya. You'll hear more of their story. I don't want to tell their whole story, but come and listen to Jacques and Agneta. They're amazing people.
So Bruce, tell us about, I know you've been, when we first met, you were kind of on a, really looking strongly at what health education programs for family medicine existed in East Africa. Tell us what the vision for CAPS is, and what do you see right now that's happening out there in family medicine? I know that there's a number of programs across Africa and I think that's such an essential piece, because even, especially family medicine that does obstetrical services and C-sections, because there are places that just are not always going to have a surgeon, and so you're filling a huge void as well. Tell us a little bit about what the plan is for the future, and what you know is already happening out there.
Thank you. So family medicine training, as I mentioned, went way back to the 80s, so predating even our discussion about surgery. But in terms of coalescing the efforts across the church hospital systems in Africa, that's only occurring now as CAP begins its ministry to come alongside what the surgeons have done so well. In a sense, we're in a shadow of great trailblazing amongst 10 hospitals. And our intention as CAP is to work alongside PACS so that we can bring the family medicine component with the surgical programs, which has an incredible dividend. We don't have to train a family physician to be a thoroughgoing surgeon then, if we're going out with surgeons as a team to go to the next church hospital that needs a good team. And that is an incredible relief of family medicine education, because a surgical trainee has a lot of things to learn. Well, family medicine does too, because we're going to try to take care of the rest of it. And in Africa, that's a lot. And so if we can, if I don't like to say it quite this way, dump the surgery onto surgeons, we're glad, okay?
We'll take it.
Yeah, exactly. And we're glad to give it, knowing that there's places where we're going to have to fill in, especially in the obstetrical side, where the general surgeons might not have as much interest or expertise. But be that as it may, we then can form a curriculum around collaboration, and know that surgeons are going to be there when we go out with the family physicians we train. So the goal is to work across the places where church hospitals exist, and as you mentioned, and you can dispute figures, but in any one country, 20 to 50, whatever percent of the healthcare, it's almost all established in the rural areas. And what PACS and CAP and we're planning to do in the future is to target those rural hospitals where the disparities are great. So when you see numbers, in tables of the number of physicians per population, those are averages, okay? And averages lie, because disparities between urban and rural are vast. In Kenya, it's 80-20. 80% of the people living rurally, 20% of Kenya's physicians working rurally. Ethiopia, other countries, it can be 90-10. So take those numbers and put another zero on the end in terms of those disparities. Now you can see the incredible work, but also opportunity for making a huge difference, both in just returning to good health care and helping systems work better, but then think of the compassion that can multiply when people are trained in the way of doing things. So at the moment, to get to your specific question, we have the Kabarak University program in Kenya that has 4 teaching hospitals, 2 of which are also PACS training sites. We have Elwa Hospital in Liberia. That's the hospital where the Ebola was. They now have a training program with Rick Sacra. The Congolese have 6 sites that are going to be a part of our team, and Nigeria has quite a few more. We're still in the formation stages. And then our service is a little bit different in that each of these countries and regions has a different way that family medicine is understood, recognized, accredited, and so forth. We have to really listen to how it's forming and happening in each of these sites so that we're recognized and accepted as a specialty. We can't always assume that that's going to happen. So we work through the systems, and sometimes that is a university thesis-based MEd. That's what it is at CABRAC, but it won't be that way in all sites. And we'll be nurturing, more sites as we are able to, and do consultations to help bring people who are interested in the work we're doing. And that's the services we offer, a kind of a smorgasbord of services that we can bring to people that are trying to do this work.
Good stuff. I have a question for you, Keir. One of the things that I've seen, and I think it kind of is the way missions has evolved, is that we want to go and teach, right? And I see that particularly challenging for, we've had a few new young surgeons who come to us right out of residency and say, I want to go teach surgery in Africa. And my reply is usually you have to go and learn surgery in Africa first, because general surgery in what you're teaching the residents really involves quite a bit of orthopedic surgery, quite a bit of even basic neurosurgery, a whole gamut of things that general surgeons don't really touch here. Is that correct?
That's correct.
And so how do you, when you bring somebody as like visiting faculty into any of the programs, how do you get somebody who's trained here in the U.S. to be able to function in your context?
Yeah, great question. So there's a couple aspects to that. If it's someone who's a specialist, they usually would be going to a program to join in with the general surgeons that are there rather than coming to fill in or cover for them. I think Greg has gone and spent some time as an orthopedic surgeon where he may be at a place that is primarily doing general surgery training, but general surgery in the way we train is head to toe, skin and its contents. So maybe not the eye, but other than that, we're doing it because people are just really suffering and dying if you don't do it. They don't have other options in a lot of these remote places, as Bruce said. So you come and plug in with general surgery residents and a general surgeon who's there, been trying to do certain things within reason. We all make errors in judgment at times on cases we should have done or should not have done. That's just the nature of being a physician. Judgment is required, and we don't always judge correctly. So having someone like Greg or an orthopedic surgeon come and partner with us to say, well, here's, with the materials you have, here's the principles you need to keep in mind, and here's what I would do. That's extremely helpful. Spending time teaching the residents. Most of the people, after they've spent short-term trip on PACS, and they've gone other places, but they've gone to a PACS site, it's very gratifying for them because they realize I didn't just go and do, I left something behind because I taught some people, and they weren't just Westerners who look like me, but they were nationals. They were people who were going to be living their careers for sure on the continent in some country. And I say continent because we're in all different countries. I can't specify a country with PACS. So that's one way to plug in. As a general surgeon, depending on your comfort level and depending on your experience, depending on the environment, some places are extremely emergency-driven surgery. Like at Galmi, 90% of their operations are emergencies or urgent. Wow. It's an amazing number of percent. In other places like Bangala, where I was, we had an overwhelming predominance of elective surgery. In a place where you're doing elective surgery, you can fill in for me because it's elective. If you're not comfortable and you don't know how to do the procedure, they come back the next week when I'm back. That's pretty easy to do. So as a general surgeon, you can fill in or even come alongside and do some work so the program director can get a break, other faculty can get a break, because there aren't a whole lot of breaks that happen out there.
Bruce, is there a way that for specialty, even internal medicine in other areas of medicine to plug into as faculty in the context of some of the family programs?
Thanks. Well, I also should mention that CAP is not just family medicine. It will be the predominant paradigm because that's the generalist is what's needed in smaller facilities. 3 or 4 family physicians need to be together to take the call. An internist, a pediatrician, an obstetrician, a surgeon, they don't take call very well. They have to do 24/7 for each of their own disciplines. Most people don't put up with that, expatriate or national. So a family physician has this this built-in utility player aspect to us that allows groups to work together better. But yes, internists and pediatricians and the subspecialties of those disciplines can plug in as short-term consultants to come and do seminar-type teaching at our facilities, so that neurologist that I worked with for a number of years at Kajabi would come each year. He was a pre-CT neurologist. The guy knew his anatomy, his physiology, his diagnostic skills without technology. He did an incredible job teaching our residents and interns during those years. So yes, they're all a place for just about anybody. I basically, talking to any physician, they'll ask, well, I don't think you need my specialty, and they'll name some esoteric thing, and I'll say, well, you know what? I have a couple places in mind where that, in fact, might actually be very useful. We're just talking to a pathologist this morning here before we started, and was unaware of some of the opportunities that he could plug into. So those of us that are a little grayer in the hair, have been around to see a few things.
Is that you or me?
Well, I think you're coming on strong there. Yeah. So yes, we invite everybody's inquiry.
Does anybody have, we've got about 2 to 3 minutes to wrap up here, then we're going to move on to the next session, but does anybody have any questions for these guys now? You're going to have an opportunity this afternoon where we're going to have a panel, and you'll be able to ask all of the speakers some questions in a little bit more detail, but does anybody have anything they'd like to ask it?
Yes, thank you. My name is Karen Smith, and I'm a family physician out of Rayford, North Carolina. I wanted to say thank you so much. The American Academy of Family Physicians actually just celebrated 50 years in our country, and to hear that you are spreading it globally is absolutely wonderful. I also wanted to commend you in regard to the community-based education, medical education. We recognize that teaching health centers in our own country does make a difference, and for learners to actually receive education in areas where they have the potential to practice is absolutely wonderful. I love the fact that you put the C word in, compassion, because often we lose that as we transcend up our medical education process. But I did have 2 quick questions. The medical students, where do they come from? And the second question, what is the role of WONCA?
Thank you. I think I can speak broadly about medical education across Africa. It's almost universally a degree that occurs after high school. So whereas in the U.S. and a few other Western countries, we do a first degree in something and then do our medical degree as a second degree, in Africa they do a 6-year MBCHB. It is in Kenya, MBBS in others in the Anglophone world. In the Francophone world, they have different letters, but basically the same process of 6 years after high school. The people that qualify to go to medical school are always chosen. I don't know of any country that I haven't heard of any country not doing it this way. It's, are you the top scorer in the national high school exam? 0.1% of Kenyans are given the opportunity to go to medical school. They are very smart. In fact, I cringe. They can memorize and spit back to me things that I can't do. My dad was an engineer. I'm a process guy. I think through problems and how to fix them, and that's the way my brain works. They can spit it out. I let them do it, and try not to let them know that I can't do it. So that's how they get their medical training. Then they do a 1-year internship almost always, which is where they're usually in the national hospital, and I could go on for quite a few minutes on this issue, but that training and the internship used to be all in the biggest hospitals, the teaching hospital, where they were not getting any of the skills training they needed. And when they left an internship, they would be posted. That means forced to go to a small rural hospital where the person who was there the year before them said, "Glad to see ya, I'm out of here, bye." That night they had to do a C-section. They'd never touched the knife to do a C-section. The scrub nurse in that district hospital was the one teaching the new graduate intern how to do a C-section. That's not always the case, but it was too much of the case. And hence, you get what I would call an emotionally scarred physician from day one. When gray-haired professors would come to us and ask, why are you doing this family medicine thing? That doesn't make sense. I did my internship when I was a GP out in those rural hospitals. What are you doing that's different? I only had one question to ask. Where did you go to do your internship? They were in the National Hospital. I knew they hadn't got the experience. Second question, where did you do your internship or your first posting? Some rural hospital out in the bush. And the third question was, so how did you feel after a month? Not one, and I probably asked this question 20 times. Not one ever gave me an answer. And I dared not give the next question. Why? Because memories were racing through their head of all the things that they wish they would have known how to learn. They were good doctors, they were compassionate doctors, they wanted to do the best, they just weren't trained. So it's not them, it's the system not giving them what they needed to do a good job. From that, they all swore off being a general practitioner forever. They all wanted to be a subspecialist of some kind, so I only had to know a little bit rather than the much that they were asked for. Hence the need for our position, our specialty.